Now, next speaker is going to be Dr. Pankaj Lande. He's going to be talking about the true trifocal, my experience with the triphobic. And I actually feel, I know this is a fantastic lens, the Tridiff lens. This is my favorite lens. And again, Sanjay Argal would agree with me. I think, again, I'm probably one of the highest volume. They're bifocal and trifocal users in the country. And I can swear by this lens. I put them in the biggest VIPs you can think of in the country, the politicians, the celebrities. And I insist on this lens, even if they want a bigger name, like I won't name the companies. If they want a big name, I steer them towards this lens. Such is my faith in this beautiful technology. Dr. Pankaj. Dr. Pankaj?
Yes, sir. I'm listening.
Your
yes, sir.
turn.
Thank you so much. Thank you so much for inviting me for this session. I would like to talk on the triphobic, that same trifocal lens as you are talking about, which I also have used with very good experience. Now we have a higher version of that, that is a triphobic, that it has come on a hydrophobic platform. So while doing this, I'm just showing a small video where I was in search of my best multifocal IOL, and while doing this, I have found the triphobic or the trifocal IOL from the care group is one of the best which I can have. Doing this, I wanted to evaluate the performance of this IOL based on the few parameters. So these IOL performance parameters was like defocus curve, the modular transfer function, contrast sensitivity, point spread function of that particular IOL, glare and halos which patient has experienced after implantation, the pupil dependency of the IOL, and the IOL tolerance for the decentration on tilt after implantation with angle, more of angle kappa and angle alpha. So taking into consideration all these parameters, I have studied triphobic IOL and found it as a very good lens where my patient satisfaction has gone up drastically. As Kapoor sir already said, when you implant these IOLs, you are sure that your patients are very happy, and additionally, they give many times performance much more than what is supposed to be very high quality lenses or very costly lenses which are available in the market. But particularly in many of my relatives also, I have used this particular lens. So coming to a defocus curve, defocus curve is basically an objective clinical measure of how well IOL is correcting the presbyopia. So it gives us idea about how the IOL is doing at various distances, right from distance, intermediate, and near. So taking into consideration all this, I have plotted few defocus curve for the triphobic IOL and has found there is not much of a dip in the center of a curve, which indicates the intermediate vision, and that gives a very good vision for intermediate. So if you are viewing through a lens of -1 after full correction, that means that indicates the vision at 1 meter distance. Same way, if you increase the lenses by 0.5 diopters gradually, and then if in case you are using a lens of -4 diopters and asking the patient to read, that it is equal to vision of patient at 25 centimeters. So I have plotted the defocus curve, which were very promising, and I have found this is one of the very good tool for evaluation of IOLs. Now the second point is modular transfer function. Modular transfer function is basically a mechanism to define the resolution and the contrast data into a single specification. It is basically the ability of an optical system to transfer contrast from object to the image at given particular resolution. MTF for clean air is 1, that is maximum, and it can be derived from point spread function and a line spread function. US FDA says for distance, the MTF should be at least 0.43, and for intermediate 0.5. This is a machine where we can calculate the MTF. Coming to the third point of contrast sensitivity. Contrast sensitivity can be simply defined by averaging the difference between minimum and maximum intensities, that is Imax and Iminimum. It can be calculated or observed with the use of Paley-Robson contrast sensitivity chart, and it gives fair idea about the contrast sensitivity. The contrast sensitivity for monofocal IOL is very good compared to multifocal IOL because there is a loss of some amount of light in the multifocal IOL. But here in triphobic, I have found the contrast sensitivity is quite good. Coming to the next point of point spread function. Point spread function is basically blurring of an imaginary point as it passes through an optical system. So MTF is basically a representation of PSF in Fourier space. This being this triphobic IOL is a ring design IOL, so it definitely indicates it is definitely pupil dependent, but the dependency is not that bad. So we definitely have to take into consideration the mesopic and the photopic pupil size of patient. Larger pupil basically tolerate slightly myopic defocus, while the smaller pupils see slightly better when the emetropia is achieved. So given a formula, if I have a 3 millimeter or less size pupil, I will target minus 0.25 to minus 0.5. And in case I have a pupil size which is more than 4.3 millimeter, the target refraction should be around 0 or 0.25. Basically, 0 will be a better option. Now, so IOL tolerance, being this is a ring pattern IOL, as I already discussed, the decentration and tilt will have impact on the IOL performance. So you are supposed to implant it in the bag with good centration and should have a good placement in the bag only. There is definitely some amount of glare and halos associated with this type of IOL design, but definitely not as that of a multifocal IOL where the amount of light dispersion is very high and that causes a very great amount of halos. So glare and halos are also slight less. I'm just showing a small surgery in the background and describing the IOL optic design. So this is one the pattern which we are seeing here is basically a bifocal apodized surface. The apodization is the center rings are more thicker, and the height of these tapes keep on decreasing towards the periphery. That is apodization. You can see for 3.5 ad, the height has to be slightly more, but for the 1.75 ad, height has to be half of that. The height and the angle both will change. So combining these two designs on a single surface will create a triphobic or a trifocal surface. Now plus 1.75 is what we are having in this IOL that will give far and intermediate vision. Now these IOLs, we can have these two surfaces combined as shown in the diagram above, that the first surface is a multifocal surface and overlying that there is a trifocal or an intermediate zone surface which is overlapped. So the IOL design here seen is the central 2-3 rings are multifocal type of rings where there are no overlapping of the rings, but later on there is overlapping of the ring, and you can see slight crowding of the rings in the mid periphery and in the peripheral region of the IOL. So this is a diagrammatic representation of a trifocal diffractive apodized surface as the height of the steps are going to decrease in the periphery. This is a modular transfer function, and this is the energy distribution where nearly 50% light of the light is used for the distance, nearly 30% for intermediate and 20% for near in this particular IOL of triphobic. and I have seen less than very less amount of light is supposed to be theoretically wasted in this design, but definitely it is something around 10 to 12%. This is the actual plot of a defocus curve, and you can note here the center area which represents the intermediate vision. It is very good, and with this also the patient's vision is quite comfortable. I usually tell my patients, most of our life passes somewhere in our somewhere in a room. It may be your office, it may be some shop, it may be some hotel, or it may be your home. So intermediate vision makes a lot of sense to everybody. Not very far distance, not very near, but intermediate is a distance which is a kind of, we can say, working distance for all of us. So I tell them that this type of vision will be much better when we go for a triphobic design type of IOL. So I definitely recommend to clean the posterior capsule very nicely so as to prevent any decentration or any capsular phimosis. In such cases, though the IOL is hydrophobic, so the chances are very less. And this is the optic design of IOL. I hope all these parameters will help you to understand the IOL performance. And I'm particularly satisfied with this particular IOL from IOCare. Thank you very much. Thank you, sir.
I think it was a wonderful presentation, Pankaj, and you did share your learnings and your experience. And I can vouch for the same. I think, at least from my personal experience, I have taken away the word of glare and halos from my consent form, especially when I'm using these IDIFs and these trifocals by Care Group, because actually patients don't know compare of glare and halos. And to my surprise, some of the very well-known, top well-known brands in the world, I have patients complaining of glares and halos, but with this particular technology, I have none. And I probably use more than 6,000 of these lenses, and we do around 150 plus a month, and amazing results, high volume. And my counselors who worked at other centers before, and once they join me, they are hesitant to counsel for a trifocal or a bifocal, but once they see the confidence of the surgeons, operating surgeons, so they have also become very, very aggressive in promoting these trifocals and bifocals, especially from this particular company. So I think fantastic technology. Again, congratulations to the company for developing such a amazing technology. What is your experience, Dr. Bianchi? Have you used these trifocals and bifocals by the company?
Yes, I have very good results also, and I use many of these lenses. I don't know the number, but I don't. The patient are without halos also, like you say.
Wonderful.
And I feel very comfortable.
Actually, I feel, Dr. Anant, we have to get you in anyway now. That's your turn. You've used these lenses?
Yes, sir. I've used these lenses.
And what's your feedback? What's your feedback?
That's what I wanted to tell you. The glares and halos with acrylic I've never come across.
Absolutely.
Trifocal number is very limited. I think post first wave of Corona, I started doing my trifocals. But multifocal acrylic I've done a n number of this thing. And the same word as you told, glares and halos, I've never noticed with my this Indian multifocal lenses. My counselors do push more into Indian multifocal. So why can't we go into acrylic more than this? Patients are happy. Word of mouth is so good for me with acrylic. And the same line I'm started off with the trifocals now. Trifocals is limited number, what I'm going to speak about.
This is what I wanted to get out from the experts here, that you see my practice of multifocals and trifocal is grown on the word of patient. They are happy, they get me more patients. And the best part is when they go to another practitioner in the neighborhood, they are discouraging them from, bifocals or trifocals, that you will have glares. But when they come to me and I make them meet hundreds of patients who are happy and they're thrilled and they're driving at night, so it turns around. So I guess once we start having confidence in a particular technology, it's